resin bonded fixed partial denture. Resin bonded fixed partial denture. As the name implies, these are fixed partial dentures which are cemented into the abutments using special resins. Composite resin bonded retained fixed partial dentures were developed from non-invasive micro-retentive techniques. So these are called non-invasive and micro-retentive. So this is the basically technique used for their fixation. Buonocore was the first person to introduce a seed etch technique. Bowen in 1962 developed the Bisgama composite resin. Right. So basically, these dentures consist of one or more pontics supported by thin metal retainers placed only on the lingual or the proximal surfaces of the abutments. So retention in these processes lies basically on the adhesive bonding agent, adhesive bonding between etched enamel and the metal casting retainer. Like these surfaces bond on the abutments without any invasion. Like we have to etch the abutments lingually or the proximal surfaces, and we have to place resin in between, and resin will make mechanical attention with these wings, and so as to retain the ponting. So resin bonding prosthesis is a prosthesis that is luted to the tooth structure, primarily enamel, which has been etched to provide mechanical retention for the composite resin. Like here, you can see this is the pontic, and these wings are attached to these abutment natural teeth. So these types of FPDs are cantilever, fixed movable, and hybrid. First of all is cantilever bridge. As the name implies, it involves the use of single retainer. So abutment tooth may be either mesial or distal side, right? Like this. These are the abutment teeth. This is towards distal side. This is toward distal side, and the mesial tooth will retain because of this. So these are called cantilever because they are retained from one side only. Why they are used? Because they are less expensive but limited to replacing one missing tooth, because they do not have any much of strength with the and retention. Fixed. One or more retainers are placed on either side. In the picture, you can see here two retainers, and in between there is a pontic. So differential movement of the can result in bonding failure because these two have their own, sometimes have their own movement. So sometimes this abutment will move, this will right. These designs of bridges indicated where excursive movement like lateral movements on the pontic cannot be avoided. Then come to your fixed movable bridge. Design is in two parts. In the picture you can see keyed together by a non-rigid attachment. The connector, these are the connectors. The connectors, which may be either ready or laboratory made, permits movement of the two parts relative to each other in a vertical direction mainly. Right. So provides stress breaking because there is movable part, so it will act as stress breaker. Should be used in short spans and where opposing proximal walls of abutment can't be prepared parallel. So there are some conditions, right? Then come to your hybrid bridge. Hybrid bridge is a different type of fixed partial denture. It's a combination of conventional retainer on one side and normal retainer on the other side. Like here, there is compromised retainer, and here we can provide bridge. So male part of the joint is often attached to the resin bonded retainer to simplify maintenance when debond occurs, right? There are various advantages of the resin bonded bridges, non-invasive to dentine with lingual and proximal to preparation, including occlusal rests, decrease pulpal irritation, right? Conservative with undeniable patient appeal and comfort, decrease tissue irritation due to placement of supragingival margins, and do not require cast alteration or removable dye preparation. There is a reduced cost also, no aesthetic needed, right? And rebonding is possible, and there is minimal tooth preparation if required. Disadvantages: criteria for choosing the patient are not discrete, demanding technique and tooth preparation. Even minor laboratory errors cannot be corrected easily. Plaque accumulation may occur because design is outside the dimension of the natural tooth. So at the space where the retainer is attached, this area may lead to plaque accumulation, right? Bulky contour may be intolerable in some patients where there is deep bite, or sometimes there is a reverse overjet. Then patient expectations of aesthetics are high, but routine results are not outstanding, and there is they are not ideal for replacing more than one tooth. Graying of the incisal surfaces, especially in laboratory, in labiolingually thin teeth, right? And uncertain longevity, we are not able to define the longevity. No space correction, no alignment correction, difficult temporization. Indications: retainers of fixed partial denture for abutment with sufficient enamel to etch for retention. Adolescent with single missing teeth, traumatic or congenital. Caries-free abutment teeth and good oral hygiene because it is difficult to maintain the hygiene. Maxillary incisor replacement, most favorable prognosis, and mandibular incisor replacements. Periodontal splints, single posterior tooth replacement. Splitting of periodontally compromised teeth, right? Medically compromised, indigent, and adolescent patient who cannot cooperate with long sessions of therapy. Prolonged placement of interim prosthesis to augment surgical procedure. For example, craniofacial anomaly. Contraindication: if patient is prone to caries, nickel sensitivity, deep over vertical overbite, extensive restoration on abutment teeth, parafunctional habits are present. Patient with an acknowledged sensitivity to base metal alloys. When the facial aesthetics of abutment require improvement, insufficient occlusal clearance to provide 2 to 3 mm vertical frictional retention in the axial wall. For example, abraded teeth. Roche Bridge was the first to design a resin-bonded prosthesis. Roche was the first to design a resin-bonded prosthesis in 1993. He used wing-like retainers with funnel-shaped perforations. You can see here funnel-shaped perforation. These are funnel-shaped perforations. Everybody knows this is the shape of the funnel, right? Perforation with the base towards the tooth surface. He also used silane coupling agents for additional retention, right? This was one of the This was one of the most widely accepted designs. Etched retainer coated with pyrolyzed silane showed up to 40% superior retention. So the perforation technique presents the following limitations. It causes weakening of the metal retainer by the perforation, exposure to wear of the resin at the perforation side. This is the area. So in these areas, there is wear of resin, limited adhesion of the metal provided by the perforations. They only retain by the mechanical retention, right? The major disadvantage of Roche bridge is that the resin exposed through the metal perforation is subjected to external stress, abrasion, and marginal leakage. Your Maryland bridge, which is also called micromechanical retention bridge. And many scientists developed different designs to overcome the shortcomings of Roche bridges. Electrochemical pit corrosion into metal. Tanaka et al. Studied retention of acrylic resin on the developed by microporosities. So this is the main important point. Microporosities. Right, present on the tissue surface of the retainer. Microporosities are created by etching the tissue surface of the retainer. Then how do we etch? The suggested etching techniques that can be employed while fabricating Maryland bridge can be broadly divided into electrochemical etching, non-electrochemical etching. And electrochemical etching here is done using a chemical electric presence of an electric gradient. Before etching, the retainer is coated using paraffin wax. The wax should cover the entire retainer except for the area to be etched. Commonly used electrochemical technique include electrochemical technique used non-beryllium, nickel, cobalt, chromium alloy. Etching is done in two stages. The first stage, the retainer is immersed in 3.5% nitric under a current of 250 milliampere per centimeter square for 5 minutes. The next retainer is cleaned by immersing in 18% HCl in an ultrasonic cleaner for 10 minutes. Right. In case of non-electrochemical, commonly used non-electrochemical technique includes leviditis. Right. We come to Virginia bridge. In Virginia bridge, these are the resin fixed partial which used particle roughness retainer. They were first proposed by Moon. Retainer wax pattern are fabricated using resin 150 to 250 micrometer salt crystals are sprinkled on the cast prior to resin fabrication. The salt crystals get incorporated into the tissue surface of the resin pattern. The salt crystals are dissolved and the resin pattern is invested and cast. Dissolved crystal will produce voids in the resin pattern, lost salt technique. Like over here in the picture, you can see there are roughness because of lost salt technique. So they are used for retention. This was a time-saving method and more retention is achieved as compared to technique of etching. Then your cast metal fixed partial denture, cast mesh fixed partial denture. So as the name implies, mesh is formed over the retainer side. Here a nylon mesh is placed on the tissue surface of the retainer wax pattern. The nylon mesh is placed on the cast before fabricating the wax pattern. The retainer do not require acid etch. But the drawback of this design include the nylon mesh may not adapt well to the cast during pattern fabrication. The wax may flow in between the mesh locking all the undercuts. So today we will discuss about the veneers. Veneers is a layer of restoration placed over the labial surface of the tooth. They are primarily used as aesthetic adjunct to discolored or fractured. Right. So these are basically applied for the increasing discoloration or generalized defects. Right. Made of chairside composite, porcelain, and cast ceramic materials. So there are various indications of veneers. Where there we need to close the space, that means midline diastema. Minor tooth position improvements, correcting rotation or overlap. Sometimes there may be overlapping of the tooth, or sometimes there may be minor crowding. Then we can correct it with the veneers. Lengthening of lengthening short or worn teeth, improving tooth shape. That means where we need to increase the smile or where we need to improve the aesthetics, then we have to lengthen the crown. Sometimes because of increased lip length, we are not able to see the tooth. So we can increase the length of the tooth, making aged teeth look youthful. Because of age, there is yellow discoloration. So we can cover that, we can mask that with the veneers. Correcting teeth in lingual version, we can make it appear buccally. Post orthodontic treatment. Sometimes, because of orthodontic treatment, there may be discoloration or non vitality of the tooth. So we can change the appearance. Shade change, brighten shade, and stain correction. Contraindication, they are deeply contraindicated to discoloration, lead to deep dentinal defects. The defect that we are not able to mask, we cannot cover that. Because after covering the veneer, we may get hue of that discoloration. Large enamel defects, hypoplasia, large diastema, which we are not able to cover with the veneers. Otherwise, your tooth will appear bigger than the normal one. That may appear as a mal, that may appear as a anomaly. Malpositioned teeth, poor restoration on labial surface, aging, wear pattern, available enamel, availability of etched enamel, and oral habits. Shape or form. There is one rule that is called golden proportion or golden ratio, also known as golden mean. Golden section or divine proportion is a height to width ratio that measures 0.618 and manifests itself in nature, art, and architecture. Golden proportion of smaller tooth is larger tooth to larger tooth is that much. Proportion of smaller tooth to larger tooth is that much. A repeated ratio, that means golden proportion only 17% of the casts. Reoccurring aesthetic dental proportion. What is RAD? The proportion of the successive width of the teeth as viewed from the frontal should remain constant as one moves distally. That means when we are looking these teeth from front side, then all the teeth should remain constant, right? We should be able to view that in a constant mode when we are moving distally. In other words, each tooth becomes smaller by a fixed percentage as you move back in the mouth. So RED is not limited to one particular proportion, but allows the desired RED proportion to to be selected and constantly applied for each individual case. Some studies have shown that smiles which maintain a constant 78% width and height ratio of the upper central incisors are preferred. Right? The taller the teeth, the smaller the RED proportion are. The shorter the teeth, larger the RED proportion used. Laminates and veneers. Meiker in 2001, laminate maintains color, usually requires no tooth preparation. Veneers, change in color, requires preparation. Endodontically treated teeth and tetracycle stain teeth. Then we have to, if we are giving anything that is called veneer, constructing a veneer and bonding it to structure is referred to as laminate. Now there are various types of veneers. Partial veneers that may be used for localized defect or as areas of discoloration. Full veneers, more generalized defects are present, and there may be if there is intrinsic stain. And direct and indirect. Direct is chairs, and indirect are less technique sensitive, more aesthetic, longer lasting, multiple teeth. That means we have to prepare it in the lab. The technique of direct partial veneers are, first of all, suppose this is your case, then outline extent of we have to measure the outline extent of the defect. Then with the coarse elliptical or round diamond burr, we have to prepare over this area up to 0.5 to 1.75 mm. Subgingival extension is done if the defect is subgingivally present. If suppose this defect is subgingivally present, then we have to move subgingivally. Microfilled or more opaque composite, depending upon remaining defect, should be used. Direct full veneer, half of the depth of the enamel, 0.5 to 0.75 mid facial and 0.2 to 0.5 along gingival margin should be prepared. So just remember this and this. So the range starts from 0.02 to 7.75, right? If included incisal edge chamfer for definitive, chamfer should be given for definitive cavity margins. Incisal edge should not be included. If included for anterior guidance, tooth reduction for at least 1 mm should be done. Shade selection is very important, so we have to take 3D master shade. Then we have to apply rubber dam with the retainer 212. Then at the margin at crest of gingival tissue. We are using processed composite veneer. It has superior properties: light, heat, vacuum, and have good pressure. We are using processed composite veneer. It has superior properties related to pressure, vacuum, heat, and light. Superior shading and characterizing, and have stable shading. Better control of facial contour. We can modify it according to our requirement. Easily repaired. Children and also adolescents as interim, they may use it as an interim restoration. Wear pattern, and it has lower cost. So for that, we have to prepare it. Window preparation. But the disadvantages: limited bonding surface, conditioning or sandblasting are required. Because of marginal bonding, there may be chances of caries or multiple large existing restoration compromise bonding. Porcelain veneer, it is most ideal veneering material when used with metal substructure or in all ceramic restoration, but it has various advantages and disadvantages. So first of all, disadvantages: repair is difficult because we have to we will prepare it in laboratory. Technique sensitive. Color modification not possible. Tooth preparation is required for strengthening. Extremely fragile and difficult to manipulate. And most important thing is it is most expensive. Advantages: color stability, good bond strength, maintain periodontal health, resistance to abrasion, inherent porcelain strength, resistance to fluid absorption, and aesthetic is far, far, far better than other restorative materials. So tooth preparation requires zero point 0.3 to 0.6 mm. Adequate space for porcelain veneer is required. We have to remove convexity also, spacer for opaquer. So we have to prepare it more. Enamel surface conducive to etching and bonding. Definitive seat margin placement is clarified. Modification of aesthetics: 5 to 15% opaque porcelain is used. Deeper tooth preparation and dye spacer engage the cement shade.